Hi, my name is Kayla Ogden. I'm a senior at Drew University, and I'm a sociology major with minors in French and Law, Justice, and Society. For my sociology senior seminar research project, I decided to do a presentation on childhood bipolar disorder, identity formulation, stigma, and the labeling theory. So, the thesis of my research is that a bipolar disorder diagnosis during childhood, informed by the labeling theory perspective, is detrimental to sufficient and sustained treatment of the child's symptoms. Frivolous early diagnosis complicates identity formulation and results in self stigmatization, perpetual low self esteem, and an aversion to seeking treatment in adulthood. So, some background on the labeling theory. Labeling theory, coined by Howard Becker in 1963, refers to the proposed phenomenon of supposedly deviant individuals identifying and consequently fulfilling the role or label of deviance that has been socially ascribed. Labeling theory is commonly used in criminology. However, the theory's foundations are present in the work of Durkheim, and it is particularly applicable to mental illness diagnosis. Key components of the theory include the internalization of the label and all its associated traits due to public stigma. Stigmatization is a process beginning with stereotyping, then social devaluation, then discrimination. Self stigmatization results in labeled people enacting the stereotypes that are put on them. So, through my research, I discovered that self stigma is not uncommon and results in chronic low self esteem, particularly for those who are diagnosed with bipolar disorder during their youth and childhood. Public stigma surrounds violence and the need for social isolation. We know from the literature that when adults are presented with children with emotions and behaviors that they regard as dangerous or as understand as being resultant from a mental illness, they are likely to respond negatively and punitively to the hypothetical child and the condition. Um, Studies have found that negative public responses include preference for social distance from both the child and their family. Blaming the children's family is also common, and that children um, who are stigmatized by the public due to mental illnesses are often experience isolation as a result. So, mental illness becomes an identity due to blurred distinction of person self from condition, and this is worse for children both internally due to the developmental period that they're diagnosed in, and that's a very, you know, between like 8 and 12 years old is really important for identity formulation. And if one is given a really heavy diagnosis like bipolar disorder during that time, it's very difficult to separate self from condition. And this is intensified from the stigma children receive from adults who obviously inform their perspective of themselves. My research also found that overdiagnosis in children is common due to multi-source symptoms. So children are um, um, It is no accident that diagnostic infiltration is focused on the mental disorders of children and teenagers. These are inherently difficult to diagnose accurately because youngsters have a short track record, are in developmental flux that makes presentations transient and unstable, are sensitive to family, peer, and school stresses, and may be using drugs. Now, this is coming from my research that I've referenced by Alan Francis and Laura Bettstara. Um, so through my research, I found that it was a lot of like faulty methods to go about treating children with mental health symptoms. So for my conclusion, I really refocused it as like an alternate approach. So one, abusive caregivers present during treatment prevents assessing child as an individual patient, ignores symptoms of familial dysfunction, which is contributive to why so many children are diagnosed in the first place, and also yeah, and so which is contributing to overdiagnosis. So one of the case studies that I read as part of my research described a young boy who was, I believe, 10 years old, diagnosed with bipolar disorder, and it documented his experiences in therapy, and it discussed one instance in which his grandma was present during the therapy session, and she was making references to the child's father, who was a deadbeat and a drug addict, and saying the child was just like him. So as a coping mechanism, the child would roll his eyes in the back of his head and pretend to be possessed by the devil to say bad things about the grandma and sort of use that as a defense coping mechanism. But the grandmother saw this as psychosis and brought it into the therapist. And luckily, she was competent enough to realize that he wasn't experiencing psychosis. He was just a child trying to deal with the fact that he's being emotionally abused by his grandmother. Um, Next, drug companies spread the gospel of childhood bipolar disorder. Antipsychotics are unevenly prescribed to economically disadvantaged children, and that this is non coincidental. Um, Next, foundational feelings of difference contributes to chronic low self-esteem. And then avoidance and selective disclosure in response to public stigma contributes to those diagnosed in childhood not maintaining mental health treatment into adulthood. Um, then stigma transferred to the stigmatizer, meaning that stigma, instead of people diagnosed in their childhood allowing the stigma to resonate within themselves, they instead transfer the stigma onto those who are, doing the stigmatizing. So then it kind of turns into like then ignorance and an aversion towards others rather than a, a self-esteem issue internally. And then finally, positive reframing of symptoms, and what I term the creative child approach, which is basically that through my case studies, a lot of them discuss how children diagnosed in their youth, there's a big trend with them being creatives, whether it be poetry or music or art. A lot of these children who are suffering with emotional regulation issues are also very talented artists. So the approach is instead asking therapists and parents to really focus on the children's skills and the positive coping mechanisms that they've already found rather than over medication and over diagnosis. Because as I've previously stated, and as a lot of the research really argues, is that diagnosis in childhood is so common because there's so many other things going on that can confuse it. So by focusing on the positive coping mechanisms rather than prescription medications and diagnosis, we can treat the symptoms rather than jumping to conclusions about what the core issue actually is. So in conclusion, reducing the prevalence of childhood bipolar disorder diagnosis would allow for efficient treatment of symptoms, eliminate internalization of label, and aversion to mental health treatment later in adulthood. Thank you very much.